This is EHJ Today at the Annual Congress of Cardiology of the European Society of Cardiology in Barcelona 2014. I'm Tom Lucier, Editor-in-Chief of the European Heart Journal, and I'm talking to Dr. Lorenz Reber, who is lecturer and interventional cardiologist at University Hospital in Bern, and to Evelyn Regar, who's Associate Professor and Interventional Cardiologist at Erasmus University. Welcome. So let's first talk about the background of the IBIS-4 trial. Why was this performed? What was the intention with and the aims of the IBIS-4 trial?
Well, it is a trial addressing the issue of high-intensity statin therapy. High-intensity statin therapy results in a substantial reduction in terms of cardiovascular outcomes, particularly in ACS patients. Large-scale, grayscale IBIS studies have shown that under the administration of high statin therapy, plaque shrinkage can be achieved. However, there is no data at all in the subgroup, in the clinically important subgroup of STEMI patients. Why is it of interest, STEMI patients? STEMI patients are known to harbor a substantial plaque burden in the proximal part of the non-treated artery, so of the non-infarct related artery. And it is also known from pathology studies and from intravascular imaging studies that these plaques located in STEMI patients in the proximal non-infarct related artery are of high risk. Additionally, STEMI patients have at the time point of the atherothrombotic event an inflammatory milieu which actually triggers the plaque growth at these sites remote to the culprit lesion. So our interest was, or our hypothesis was, that a similar plaque shrinkage can be achieved in STEMI patient as compared to stable coronary artery disease patients, despite this milieu which seems to provoke plaque growth.
Okay, so basically you studied STEMI patients, and so what was the design of the IBIS-4 study?
So the IBIS-4 study was nested into the international randomized comfortable AMI trial, which was a trial comparing a drug-eluting stent versus a bare metal stent in the primary PCI setting. Patients were eligible if they were presenting at 5 pre-selected sites, mainly in Switzerland and in Copenhagen. And if the primary PCI result was good with an established TMI greater than 2 flow, and in the absence of significant disease in the 2 non-infarct related arteries. If this was the case, we performed intravascular imaging using IBIS, radiofrequency IBIS, and OCT in the 2 non-infarct related arteries. Patients received 20 milligrams of rosuvastatin for 2 weeks, followed by 40 milligrams, that's the highest dose available and FDA approved, let's say, for the remaining study period, which was 13 months. At 13 months, the imaging was repeated in the identical non-infarct related artery segments.
Okay, so how many patients did you enroll?
We could enroll a total of 103 patients at immediately after primary PCI, and serial imaging was possible in 80%, which refers to 82 patients with a total of 146 non-infarct related arteries.
Right, and the high-dose statin therapy was well tolerated?
The high dose was very well tolerated. According to the new American guidelines, high-intensity statin therapy is defined as either 20 or, in brackets they mention 40. If you consider this definition, more than 95% of patients remained on 20 or 40, and actually 70% well tolerated 40 milligram throughout 13 months. This was reflected by a tremendous effect on the LDL-C level with a reduction of 45%.
So what was the average LDL level at the follow-up period?
It was 1.9 millimole, and 43% of patients were under the recommended level of 1.8 millimole per liter.
Okay. That's a very, very substantial decrease, right? So what did you find?
So we were actually looking into two aspects. The first was the effect on the plaque burden. And we could confirm what has been shown mainly by the Cleveland Clinic team, a significant reduction of roughly 1%, specifically 0.9%, a highly significant reduction in plaque burden. The second...
That's the plaque volume, or?
That's the plaque burden. It is defined as the percent atheroma volume.
Okay.
And this is very consistent with previous mega trials like the asteroid or the Saturn, which showed a similar results.
Okay. And what about the other endpoints?
So as there is, let's say, a lack of correlation between the plaque shrinkage, which is modest at best, and the observed substantial reduction in cardiovascular outcomes in patients receiving statin therapy, the next logical question was whether the statin-mediated effect might be explained by plaque changes in plaque composition, and that's why we looked into the plaque composition by radiofrequency IBIS, and specifically the percentage of necrotic core. However, we could not detect any change in necrotic core over 13 months.
Okay, good. So, Dr. Rigger, what's your opinion about the study? We were seeing that there's a highly significant decrease. It's a surrogate endpoint. It's a small change. Is this clinically important?
First of all, I think the team and the IBIS-4 investigators should be congratulated for their effort, including multivessel imaging in patients with myocardial infarction, which puts burden on the cath lab team, and I think that is something that must be recognized. What have we learned from that effort? I think it's very important to understand that we learned that obviously in patients with acute myocardial infarction, statins seem to act the same way like it does in patients with stable angina, because we see consistently throughout the studies a small but consistent reduction in atheroma volume. And I think that is very good news to our patients. We really can halt or maybe even reverse the process. So I think that is important to note. My second comment is the second endpoint. It is quite sound to speculate that this mechanism of action somehow must affect plaque phenotype. And the question that we have, of course, is what is the best way to diagnose changes in plaque phenotype?
Exactly.
The tool that we had in our hands as interventional cardiologists a couple of years ago was IBIS. Grayscale IBIS is not sensitive in visualizing plaque composition. The next step was a technology evolution, developing radiofrequency analysis, and the IBIS-4 trial is now one of the trials where we are learning whether or not this new technology is suitable in giving the answers that we are looking for. When we look to the study, the result of the VH analysis might be somewhat disappointing because we don't see a clear signal. And this is something that we still yet have to understand in the future. What are possible explanations for that? To me, it's always puzzling if you look throughout all published VH studies, then there is always a strikingly high incidence of red color and of VH-defined so-called thin cap fibroateroma. And that is somehow in a mismatch to clinical events. How do we interpret that? maybe we need to rethink our definition of VH, thin cap fibroateroma. It has a lot of unknown variables in the definition. For instance, IBIS has a resolution of 200 micron, so it's virtually impossible to detect any thin caps that are below 200 microns. Nevertheless, the definition of TICFA requires that, and VH is doing an approximation to that, and so on. So I think here there is clearly lessons to learn. On the other hand, we should also not forget that now this field is triggering so much interest that there is more and more sophisticated technology coming available for clinical research, that we will be able to elucidate these points further on.
So what new technologies could be considered in the future to better understand these results?
One of the technologies that is around is OCT, optical coherence tomography, and it has also been applied in the IBIS-4 studies, yet the results are not yet available. OCT has some advantages when we are looking at these sort of questions, because it has a very high resolution. Yes. That means that it can visualize plaque structures with high accuracy. We are talking about an in vivo resolution about 20 microns. Mm-hmm. So now suddenly we have a tool in our hands to diagnose in vivo and over time truly thin cap fibroateromas.
And changes in the cap size.
And changes in the cap thickness. There is an interesting exploratory pilot study from Japan, from the group of Professor Akasaka, who showed that patients with acute myocardial infarction treated with high-intense statin therapy show an increase in fibrous cap thickness over 6 months. Mm-hmm. So there is more and more data coming out that we are truly affecting plaque morphology, and the question is now, how can we best detect that? Another technology that is very interesting in this respect is near-infrared spectroscopy. Yes. That's a technology specifically designed to visualize and to detect cholesterol esters within the coronary wall, and also this is, I think, a very promising approach to better understand these detailed chemical and morphological changes of the artery wall.
Angioscopy has been used in the past. Do you think there is still a value to it in this regard?
Angioscopy has been used in the past. Angioscopy allows for fascinating insights into the coronary wall, but it also suffers from some limitation. One of them is the lack of being able to quantify angioscopy. Mm-hmm. So you can see yellow color or whitish color. It's mm-hmm. very tough to quantify the appearance, and this is even more complicated if you're talking about longitudinal studies, where ideally we would like to have repetitive measurements in a patient.
So when will we have the OCT data available to better understand what you found?
Exactly. Well, I think in approximately 6 months from now, we hope. It's very laborious, I must say. It is an analysis that is based on visual estimates, and you need to be very careful to have to avoid an intra and inter-observer variability which is too low. So people who are analyzing it must be very trained and must prove that they are able to reproduce the results. These are important caveats when it comes down to the analysis of OCT. So we try to really perform a careful analysis in this respect, but I fully agree what Evelyn said. It will be important in the future to seek for even more sophisticated imaging technologies than probably radio frequency IBIS is. I mean, the histological validation has been at least debated, whereas, for example, NIRS, which you mentioned, has already received FDA approval. Right. So there seems to be some kind of discrepancy in the degree of validation of these different techniques. From the OCT, we expect not only insight in terms of the fibrous cap thickness, but also in terms of the inflammatory activity in the vessel wall. Specifically, OCT has the potential, or has been validated, for the detection of macrophage accumulation. So this will be another eventually relevant insight.
So, okay, so we'll look forward to that. And where can we read the results you just presented in the hotline?
They were due to many efforts from the author side, but also from the editorial team of European Heart Journal. They are available since yesterday online and will be in print very soon, I guess.
Good. Thank you very much indeed for this interesting discussion.
Thank you.